I think we'll go ahead. All right, well, good afternoon, good evening, everyone. My name is Karen Gorleski, and I am the CEO of ASTMH. It's a special honor for me to welcome you to the first of the Fireside Chats that we will be offering this year. Today, we have the extraordinary opportunity to hear Dr. Julie Jacobson and Dr. Bill Foege talk a bit about how compassion, culture, and courage are influencing and can influence people's lives and work. These three, compassion, culture, and courage, are the framework for Julie's vision for the society this year, including the theme for this year's annual meeting. Julie, of course, is president of ASTMH, and Dr. Foege, simply put, is a global public health leader on a scale that only a handful ever achieve. Dr. Foege, we are deeply grateful for your lifetime of dedication and your willingness to share a little bit of your time with us today. I know by this 1 year of Zooms on during COVID, you are quite expert at the whole Zoom stuff. So before I turn it over to Julie, I also want to partner for this chat, FACE, that stands for the Focus Area for Compassion and Ethics, which is a program of the Task Force for Global Health, formerly known as the Task Force for Child Survival, not so coincidentally co-founded by Dr. Foege. So over to you, Julie.
Thank you, Karen. Thank you for that wonderful introduction. And I'm delighted to have Bill here with me today. Bill, I think, you need no introduction. I think you all have read a little bit about him in the email that came out, and Bill's pivotal role in smallpox, director of the CDC, executive director of the Carter Center, founder of the Task Force for Child Survival, now the Task Force for Global Health, and senior medical advisor and trusted advisor to the Bill and Melinda Gates Foundation and Bill and Melinda. And I have to say, I'm very proud to have Bill as one of my friends and mentors in my life. And so thank you, Bill, for joining me for the very first Fireside Chat. I so wish we actually had a fire and we were side by side, but at least being on Zoom, we don't have to wear masks, so we can see each other's faces, and that's a delight for me. I thought first I'd say a little bit about the theme and how this came about, and then move into our conversation today. So coming into presidency of ASTMH, I was president-elect in 2020, and I was thinking about what were the challenges for the society and what we needed to do and think about. And 2020 was a challenging year for everybody. Everybody globally is stressed financially, physically, emotionally. And three things for me emerged that were either acute or chronic stressors for us. And one of those obviously is COVID. The second that was coming up and being a recurring theme was climate change. And the third one was colonialism from the perspective of the society, brought up by the institutionalized racism that's been a part of the challenges of our country and other countries. And so in thinking about those, they seem so hard to overcome. And I really wanted to have a theme for the year where we start to nurture the tools and the ways in which we can help to come up with constructive ways to overcome those. And that came for me into the 3 C's that I would combat the 3 C's of COVID, climate change, and colonialism is compassion, culture, and courage. And so that comes into the theme for this year. And when I think of those 3 words, your face immediately comes into mind. I think for me, you embody all of those. And so I'm really, really thrilled that you agreed to be my very first Fireside Chat in this. And so I'm looking forward to talking with you about how this is manifested in your work and your life. When I think about us that work in global health, and we have such a privilege to step into different worlds and different communities in a very meaningful and very intimate way, and that this comes with incredible challenges and opportunities within that, and ways in which there's creative problem solving. So I think you've been doing this for your whole life, and I've wanted to come to you with this first question, asking you about compassion and the role that compassion has played for you in your work and your public health career.
Well, thank you, Julie, for having me, first of all. And thank you for developing this theme. Compassion is a more difficult subject, I think, because we all say immediately, yes, we should have that. But some years ago, I was lecturing to medical students at the University of Washington. And I was telling them about how 20 years ago, I needed to have surgery for cancer. And so I started talking with colleagues there, trying to figure out who do I want for my surgeon. And I found that I was looking for two things. I wanted someone that was technically superb, and colleagues would know that. And number two, I wanted someone that was so competitive they hate to lose. But I didn't think of compassion. I wasn't looking for compassion. And then as I talked to people in global health, they didn't actually question people about their compassion before they hired them. But as I said to the students, I got to know my surgeon and we became friends. And what I didn't realize in that lecture, he had snuck into the back row of the auditorium at the University of Washington. And I'm so glad I continued to say, I got to know him and found out he became a surgeon because of compassion. And so compassion may be the thing we seek, but there's not a good measure of it. But consequential compassion, you can measure. And that's the two words together, I think, indicate what we should be looking for in compassion. The consequential compassion. What are the consequences? Because you can measure those. Many years ago, I sent a memo to the president of Emory University, making some suggestions on how the medical school could become the gold standard. I made 4 suggestions. Number one, you don't teach compassion in graduate school. And so compassion should be something that you seek in people who want to go to medical school by looking at what they've done. What are the consequences of their compassion? And then those are the people you want to invite into medical school. Number 2, I said, medical school should make it very clear that students are seeing indigent patients not because they're easy to work on and they don't have other outlets. They should be doing this to demonstrate the compassion of the medical school, to be able to use skills and knowledge for those people. The third thing I suggested is every medical student should have a period of time in another culture. And number 4, that every medical student should graduate with an MD and an MPH degree. Because the MD degree is looking at numerators. The MPH degree is looking at denominators. And to have training in both numerators and denominators seems to me to be a very important thing. Interestingly, I've repeated that memo to every president of Emory, and all of them have agreed except one, who did not agree with the first thing. He said, if you insist on a demonstration of compassion before you will admit them, you will miss some of the best minds in the country. And my reply was, no, you'll miss some of the best minds that don't have compassion, for sure, but not some of the best minds. So compassion is something we should measure by what are the consequences.
That's great, Bill. And that's so interesting because just reflecting on the piece of medical students and having experience with a different culture, I think that is such an important piece. And, you know, in my history, I started a group called Project World Health when I was in medical school with the main piece of having medical students go and spend time in a country and then bringing them back and spending time with us, because it just broke down so many of your preconceived notions of what you thought you understood, and the fact that you know, being a medical student, you have to know everything all the time and you always have to be right. And you go into another culture and you realize, I don't know anything. All these rules that I thought were right and I'm understanding how the world works, it's very different from that. Yeah.
At my 50th medical school class reunion, one of my classmates said to me, you won't remember this, but we had lunch once. And I asked you what you were interested in, and you said global health. And he said, I said to myself, what a waste. And now I'm here to apologize.
That's great. And clearly I can say that was not a waste. Well, my second question has to do with, and I think this is a nice segue into the tropical medicine and the roots of tropical medicine being in colonialism. And I'm curious about whether you've seen that in your lifetime and whether that's changed and what your thoughts are on that piece, which is a concern about how we grow and be equitable in global health.
Colonialism was an important part of tropical medicine and global health. And it was different in Africa compared to South America, compared to Asia. I'm working right now with 5 graduate students looking at the history of global health. And we find that it's far more complex than we thought, because it involves not only medical missions by church groups, but it involves colonialism, and oftentimes the two were mixed. It involves military groups trying to keep their troops healthy. It involves literally thousands of non-governmental organizations. And particularly after the Second World War, it involved global agencies, WHO, UNICEF, the UNDP, World Bank were all formed. Many bilateral agencies, USAID, Canadian CETA, Swedish CETA, and so forth. But then it didn't stop there. Pretty soon you had universities becoming interested. Oftentimes people would go over and do a paper that they would publish, and it might not actually change what happened in the country. Then you had the last 3 chapters, which is when you get politicians involved in global health. And I think President Carter is an example of that, because if I go to an African country, I can probably get an appointment with the Minister of Health. I can't get an appointment with the head of state. Jimmy Carter could go and talk to the head of state. And I can tell you, if the head of state becomes interested in guinea worm, the minister will also become interested. So it was a way of accelerating what could be done in global health. But then another chapter, which was the pharmaceutical companies, the philanthropy from pharmaceutical countries, which people see can't be done, and it can be done because you have many people in companies who are altruistic. And Merck in the 1980s came up with a drug for heartworm in dogs, ivermectin. And then they found that it could prevent the blindness due to river blindness and due to onchocerciasis in Africa. And they made the decision to research that even when they realized that they were not going to make money on it. But Roy Vagelos was head of research and presented the money to them. Then he became CEO. And when they realized they had a drug that actually worked for the poorest people in the world, required only once a year versus every month for dogs, and they couldn't make a profit on it, they attempted to give it away free, first to WHO, then to USAID. And they finally came to the task force because they were having trouble getting people interested in this. So that then led to other companies. GlaxoSmithKline provided albendazole so that Merck and GlaxoSmithKline could now treat lymphatic filariasis. And this has led to Pfizer and others becoming very much involved in global health. But then the last chapter is the new philanthropy. And I think when we finish the book on the history of global health, we'll find the tipping point really came about the year 2000, when Bill and Melinda Gates became interested in global health and made this a reasonable approach to solving health problems in the world.
That's really fascinating. I look forward to reading this book.
Well, and you know, we're also finding that the motivations of the individuals are so different. I mean, some of them wanted to share their medical knowledge. Some of them were interested in the excitement of going to a new place. Some of them were just curious about everything. Some of them were simply employees of military establishments or of colonial governments and so forth. So there were many different motivations, but you put it all together and it's become really quite a force in the world.
Very powerful. Yeah, and there's so many sub-stories within that. I mean, I think, you know, you mentioned Merck, and then GSK coming in, two competitive companies, you know, voluntarily working together to solve a global health problem.
That's
and
right.
to put their two drugs together to treat millions of people is just, I mean, that's a story that isn't commonly talked about. And it's just amazing the things that can happen when people align around a shared goal to accomplish something on a global health level.
Right. Yeah.
Yeah. So this leads me naturally into my next question, which is about global health and working with different cultures. So, you know, every time you step in, and it hits me all the time when I am working and step off the plane into a country, and I'm there interacting with people and communities, and you have this idea of the project that you're going to do, right? The thing that you're there to help with. And then all of a sudden you're hit with just the richness of the culture that's around you and all of the things and how ignorant you are to all of those other pieces. You know, you're Parasite, but then there's all these other parts. And so interacting with these different cultures can be exciting and challenging and sometimes embarrassing. But I was wondering if you could share any stories where culture played a role in your success or a setback.
So what you say is absolutely true, that it turns out to be a whole new adventure. And when I look back at some of the most exciting moments for me, they have been when I have been sitting in a room or around a table with people of different cultures where we're trying to solve a problem. And then someone comes up with an idea that you would never have thought about because from their culture, that seemed to be so obvious. And you realize that this kind of diversity is not just politically correct. It's the way to get a better answer. And so working with tribal leaders in Africa helped to improve what we were doing in the smallpox measles program. The same with leaders in India. And I don't know how often I was saved from making a big mistake by someone saying that's not a good idea. And this is why. And then you think, okay, yes. I mean, I would have initially been trying to get them to give rewards for smallpox, not knowing that in 6 days' time, we were going to find 10,000 new cases that no one knew about. I mean, we would have gone broke. And they said, no, don't do that, don't do that, until we got down to a low level. So yes, it's exciting. And we actually had a chance to live in a village in Africa with no running water, no electricity, no indoor bathroom, and a 3-year-old son. And so it was an opportunity to try to figure out what is different. Why is it that we can live with a 3-year-old in this village and not worry while other people have to worry? And it came down to very simple things. Number one, knowledge, that we knew to boil the water, screen the windows, and use malaria prophylactics. And number two, money. If we had been limited to $2 a day, it would have had to go for food and shelter, and you couldn't buy these things. So very simple things, knowledge and money were the difference between the risks my son took versus the risks their children took.
Yeah, understanding those different contexts of the people that you're working with and the stresses that they're under and the challenges that they are really can mean the success or failure of different pieces of work. And I really like that, bringing in the local knowledge piece too, because, you know, again, it's, you know, these problems are complex and linked into many, many things that that are well understood locally. Yeah, so thank you for that. I'm going to move into my third category, which is courage. And I think that we are going to need a lot of courage to stand up to the challenges that are affecting us as a planet and as a human species in the years to come. And I was reflecting in the last year on you were very courageous in writing a letter to the former director of CDC as a CDC director to a CDC director. This is a private letter. It was not meant to be made public, and then it got leaked to the media. And then you were forced into the spotlight with a letter that was really intended to be private, and you had to you stood up at that time and used your voice. And I was wondering if you know how you found the courage to speak your mind and what you think about finding courage to speak.
Well, I should say it took no courage because I thought it was a private letter. But here's what bothered me. It was clear that the political interference with CDC was halting the regular public health approaches. And I kept thinking that the White House task force is going to see that this isn't working and they would change. And they didn't. They just kept digging in deeper and deeper. And so one day when something just bothered me terrifically, where the administration put on the CDC website information that CDC never would have approved on their own. And I did not bother to ask anyone else for advice. I thought, I'll do this on my own. And I sent that letter without sharing it with anyone except my wife. And so when it became public, there wasn't as much backlash as I expected, but there was some. And of course, it was political backlash. Now, the problem here is that obviously politics interfered with public health. But don't come to the wrong conclusion. Don't say we have to keep politicians out of public health. The conclusion should be exactly the opposite. We need politicians involved in public health. We're so totally dependent on politicians. We are a single payer system in the medical environment, that all of our money comes from the government. We have to have the politicians actually educated. So it would be a mistake to say we don't want politicians. What we don't want are bad politicians. But you know, we don't want bad politicians involved in anything. So I have come to the conclusion that it's difficult to get good politicians. In the early part of our history in the United States, when we had so many really outstanding people, and you know, I think of Franklin and Washington and Jefferson and so forth. Back then, people of real knowledge only had about 3 different professions they could go into. They could become ministers, they could become teachers. But nowadays, there are so many other things you can get into, computers, into science, all kinds of things, that we don't have the same sort of people going into politics. Mm-hmm. And we've got to encourage good people. And so I would think the audience today, plus all the students I talked to, I said, some of you should be going into politics. It's a shortcut into getting people who understand public health into the political system. And so I urge students to consider this as a possibility in the future.
And that takes a lot of courage. I mean, it's a whole different, we talk about different cultures. That's a huge different culture going into a political landscape. And that's a really interesting and important perspective that maybe that'll become a subspecialty in the political science, global health, public health. Maybe that already exists. I don't know about it, but interesting piece.
Yeah, and particularly when you think about the silos that develop in universities, public health should be covering everything. The president of our class, when I was an MPH student, was a Nigerian. And he wrote in the yearbook that there is no area of knowledge beyond the ability of public health people to digest. And because he said this is just such a universal profession.
Interesting. And it does have to be all encompassing, because you think it has to do with behavior, you know, climate, exposure, culture, all of those pieces coming together to affect people's health, wellness, and behaviors. Yeah.
Yeah, public health people should become very interested in climate change, and they should also become very interested in poverty. Those 2 things could really make a difference if public health people embrace them.
Yeah, and it comes back into your example of living in the village, you know. Poverty was one of those big drivers that made the world a very different place. Yeah. Exactly. Yeah. Well, I think when I convinced you to do this, Bill, one of the things that I did say is that if you had any questions for me, I would entertain those as well. I have one final question for you, but if you have something you want to ask me, I welcome you to that.
Well, I'd be very interested in why you went into global health. There has to be a story behind that. And I would also be interested in what's been a high point for you thus far in working in global health?
Ooh, big ones. Okay, so global health for me, I mean, I guess it's interesting because I guess it comes into part of my family history. My grandfather was a medical missionary in the 1930s in what was then Belgian Congo, then became Zaire, now Democratic Republic of Congo. And he went over, took a steamship and then a rohi to go up, and then, you know, started building a hospital in the 1930s. And so I have that history piece in my family. And I always knew I wanted to do global health work. I wanted to be of value to any community that I went to. So becoming a doctor was a way in which that I knew anywhere I went, I would have some value that I could offer. And yeah, so I think it came in from a very early age. And it really, my understanding of the piece came into an early trip that I did. And when I was, I guess, 16 or 17, and I went and we stayed with communities in Jamaica at the time, and we helped build a school and do this little summer school thing and stuff like this. And it was that understanding. I realized that I had no idea anything about the world, you know, because at that age you kind of think, I got a handle on this, you know, I see the way things work, I'm getting the hang of this. And then I went there and I realized it just exploded my world to realize that because people were so poor and they were the richest people I'd ever seen in my life. You know, they had such life and celebration of each other, and it was just so beautiful. And they had such a deep generosity that was part of their souls. And I realized that how much of my culture was affecting my view of the world, and that I really wanted to do things globally. And so choosing to be a physician was kind of a natural piece for me. Then highlights. So I have two that I can't choose between. I worked on a disease called Japanese encephalitis, JE, and when I first became aware of it, it was like, you know, like a paragraph in the textbook on tropical medicine. I read my paragraph, thought I'm ready for this, and went and then saw just the devastation that it causes in developing countries. Where like it was in India at the time, and like there were 2 to 3 kids per bed, unconscious, seizing. And I'm like, this is a medical emergency. Like they should. And they're like, oh, this happens every year. And there was a vaccine for it, and the kids weren't getting the vaccine, and I was like, that's just atrocious, and so I went into trying to solve that problem, and it's a longer story to get there, but the first JE vaccine that made it into the system in India, my highlight.
Great.
My highlight.
Great.
Yeah.
And when you mentioned Jamaica, Michael Manley, who used to be prime minister, said poverty shared can be endured. But the problem is it's no longer shared because we have such knowledge of everything else in the world. That
is so interesting. Yeah. There's such power in the information that we can share, and then such liabilities with it when we look at the outbreak of misinformation that we have currently. That brings me into my final question for you. So do you have any advice you would give the next generations that are coming into this space, and through your experience and the legacies of the work that you've done? What would you say to inspire the next generation, in addition to becoming a politician?
Well, I tell students that if you are interested in global health, I can predict you won't become rich. And I can predict that you will not be thanked. But if you get beyond those 2 things, it can be a very satisfying field. And then I tell them about Pearl Kendrick, that even people in public health seem to have forgotten Pearl Kendrick. She was working for the Michigan Health Department in the 1930s and was a co-developer of pertussis vaccine. And when she died, I think it was 1980, the Dean Remington at the University of Michigan School of Public Health gave a little talk, and he said there are hundreds of thousands of people alive because of the work she did with pertussis. And he paused, and then he said, "Can you name one?" He said, "I can't either." And so he said she never really got thanked. But she was so certain of the contribution that she had made that she didn't need to be thanked. And so if you're going into global health, don't expect to be thanked, but it's a satisfying field.
Beautiful. Well, thank you, Bill, for your time, for your wisdom, for your experience, and for your lifetime of work, and for your continued work in this book on global health, history of global health, that I look forward to participating in the reading of and learning from. And thank you for being my first Fireside Chat. And thank you to all of you who joined us today, and look forward to the next one. Stay tuned.
Thanks for having me.
Yep.